Webinar number 42. We are here for the wrist and hand mechanics and their implications into clinical practice, especially from a physical therapy or a movement science perspective. A wrist, usually called as the wrist complex, but justifies the term because we have too many joints that forms this pivot joint, which is a biaxial condyloid type and then pivot. This is like, for example, you have all the movements almost like a ball and socket, like a multi-axial, for example, like flexion extension, ulnar radial deviations. You also have a bit of supination, pronation, okay, and so there is a lot of things that is available here, okay. So it starts with the distal radioulnar joint, then it goes to radiocarpal joints and ulnocarpal joints. Then after that it goes to intercarpal joints, okay, between each of the carpal bones, ranging from the scaphoid lunate, okay, triquetrum, pisiform, okay, and then you have this trapezium, trapezoid, capitate and hamate. Okay. What else is there is also the radiocarpal, that is a combination of not just the scaphoid, okay, it's also with the lunate, that is the maximum component of the wrist joint, okay, compared to the ulnocarpal, which is the ulnotriquetral, okay, that's a medial. And you have this, next is the midcarpal, that means between the proximal carpal row and the distal carpal row there is a joint, that is midcarpal joint. And then carpo-metacarpal joints, okay, all of them are enveloped in the single capsule. Okay. So the mechanics of one bone will eventually influence minimum 4 bones, okay, around. So if triquetral is moving, then pisiform, capitate, hamate and then ulna, okay, all of them will be influenced. So only pisiform, for example, it's attached only to the triquetrum. Okay, otherwise you see all the carpal bones can influence multiple. And carpo-metacarpal joint of the thumb, that is actually again a saddle joint, which is again a biaxial joint. Okay. So you have movements of the thumb, which is like abduction, okay, flexion, extension, adduction, okay, and then circumductions of the thumb. And fingers, of course, flexion, extension. It can happen at the metacarpophalangeal, or it can happen at the proximal interphalangeal or distal interphalangeal, and you also have the abduction adductions that are happening at the metacarpophalangeal joints. So that's the movement that are available, okay. So that is actually what we are actually analyzing, okay, movement analysis. So try to see this. And the next thing when you are observing a movement is actually for the stability. So if you are asking the person to hold an object, okay, like a hand grip. So during gripping action, if there is wrist pain, okay, eventually suggests the instability, carpal instabilities, which can be dorsal intercalated segmental instability or the volar intercalated segmental instabilities. And even gripping can produce clicks in the inferior or the distal radioulnar joint, so instabilities also, okay. It depends on the localization of the symptoms, okay, which region it is. Most of the times it is localized to that area, okay, and then further differentiation regionally you have to do both kinetics and kinematically. What we actually see here in the wrist is the skeletal alignment first. So remember that radius styloid process is more distal compared to the ulnar styloid process, okay. Radius styloid process is more distal. And compared to the ulnar styloid process, radial distal styloid process is also more anterior, okay. So it gives a bit of a pronation assist, okay, because the radius is slightly anterior to the ulna, okay. Anterior means palmar. And you also have this anatomical terms like anatomical snuff box formed by the abductor pollicis longus and extensor pollicis longus and brevis tendons. And this snuff box is the area where you palpate for the scaphoid, okay. These tendons are important for the thumb, especially they are the main extrinsic muscles of the thumb, like how other fingers also. Extensor digitorum is very important because the expansion goes to each and every finger, and from the extensor digitorum tendon only the extensor expansion comes here, and insertion of lumbricals, palmar intrasay, dorsal intrasay comes there. Okay, so if extensor digitorum is weak, intrinsic muscles will be weak. Okay, because anatomically itself it is related. And the next, of course, wrist extension will create lengthening of the finger flexors, because stretched at the wrist, so they can act more strong at the fingers. So it will prevent what is called as active insufficiency that will occur in the wrist flexion position. If you are trying to grasp objects, grip will be weak, but wrist extension, the grip will be strong because it is lengthened at the wrist. Okay, so extensor's activation will help the finger flexors to hold that gripping, for example. So if you are analyzing the movement, that means you have to see whether subject is able to hold it in a normal position, or the subject is doing a overactivity of the extensors and then doing it. It may be a compensation or an irradiation, because from proximal to distal, okay, you are substituting the muscle action. If you are flexing and if the grasp is weak, you know that wrist extensors are weak. Or the flexors are overactive, wrist flexors are overactive. That happens in hemiplegics. Okay, so that's why they tell that work on wrist extensors, and after that you train the gripping tasks. Okay, in upper extremity rehab after a stroke. So here stability, you are talking about the bone alignment. Okay, carpal bones, you see that they are stable only with the ligaments. Okay, you cannot fully stabilize the carpal bones. Their movement is very, very important. Functionally, the shock absorption, okay, it's there in the upper limb. Main commonest mechanism of injury is the fall on outstretched hand. Okay, so the primary shock absorption happens at the wrist, and after that the forces gets transmitted. When the wrist is fully extended, then the force gets transmitted to the further part of the upper limb. Okay, so you also should be aware that something which is important, and you cannot stabilize the wrist with muscles. You can only stabilize the wrist with the external supports. Okay, if you want to stabilize the hand, then you can do it with the intrinsic muscles. So you can have the lumbricals to contract, okay, with the 90 position of the MCP with the fingers extended, or you can contract the palmar intrasay for adduction and dorsal intrasay for the abduction with the lumbricals action. Lumbricals originate from flexor digitorum profundus. So again there is an interrelationship with the long finger flexors gripping. So if lumbricals are weak, then flexor digitorum cannot act. Okay. Superficialis flexes the proximal interphalangeal, whereas the profundus flexes the distal interphalangeal, in addition to all the joints that they cross, MCP, wrist and also elbow. Okay. What is here important for when you are seeing for the osteokinematics, for example, I have told about the movements. Remember that extension is always lesser than the flexion. Okay. Ulnar deviation is more and radial deviation is less, because of the styloid process being more distally there, radial styloid process. And you have a supination which is lesser than the pronation. Okay. For the distal radioulnar. So in differentiation approach of the AOMPT, I have told you that you can supinate and then you can flex and extend, or ulnar and radial deviate, pronate and then flex and extend, and radial and ulnar deviate, in order to rule out the distal radioulnar joint dysfunctions. Okay. So similar biomechanical principles can be used to differentiate multiple joints which are either closer to each other. This wrist, you can also see the kinematics, the orthokinematics. You can see individual carpal bones which can glide in anteroposterior directions. You can check the intercarpal ligaments. Okay, and don't try to check the capsule of the wrist. It's very tough to check. Because ligaments only support loose capsule, it's an extensive capsule. And you are talking about the arch of the palm. Okay, you have the palmar creases. Okay, right from proximal we have the flexor retinaculum, the wrist creases. Okay, flexor retinaculum, which binds pisiform, hook of hamate, crest of trapezium, and the tubercle of the scaphoid. Okay? And it gives deeper to the flexor retinaculum. Most importantly, we see the flexor tendons and the median nerve. Okay? When we talk about the medial side, we have the Guyon's canal, which is bound by the pisohamate ligament, okay? And ulnar nerve goes within that. Okay? And hook of hamate or the pisiform is the hypothenar muscles of the little finger, they are originating. Whereas from the trapezium and scaphoid and also from the first metacarpal is we have the intrinsic muscles of the thumb, that is called as the thenar muscles. Okay? Palmar and dorsal intraossei, they originate from the metacarpal shaft, anterior and the posterior surfaces. Okay? So remember, the role of the mechanics of the palm depends upon the structure of the palm, the shape of the palm, okay, and also in the structure you might see the arches, the palmar arch. Okay, we have the longitudinal arch, we have the oblique arch, okay, and transverse arches, okay, that is also present in the palm, which are all predominantly controlled by the palmar aponeurosis, which is an extension of palmaris longus tendon. Okay, and you have even the bulk of the thenar and the hypothenar, they form the major arch of the palm. Anatomically, of course, anastomosis is also the radial artery, ulnar artery anastomosis in the palm, so that is also an important landmark there. All the tendons, the flexor tendons, superficialis or the profundus, have synovial sheaths covering them for the smooth gliding of the tendons. So they also are potential sites of dysfunction and injuries. Okay? Palmar branches, digital branches, lateral 3 branches are from median nerve and the medial 2 branches are from the ulnar nerve. Okay? And posteriorly, wrist, radial nerve do not extend below the wrist. Okay? So it ends at the ganglia. Okay? It forms a dorsal ganglia and it ends. Okay? When you are talking about this wrist mechanics, predominantly there are gross motor, fine motor or gross movements and fine movements. Functionally they are classified into the pinch and in the grip, and you have this different types of grips which are like spherical grips, cylindrical grips, hook grip, okay, hook grips, and you also have the precision grips, that is the what is called as the pinch, tip to tip, okay, pad to pad, okay, pad to side, okay, or side to side grips. Okay. Side to side intraside, this is opponent's pollicis, the pad to side, okay. Tip to tip is longus, okay. Flexor digitorum profundus, flexor pollicis longus, okay, tip to tip. So different muscles work for this. But remember, although the extrinsic muscles are working, the long muscles, the intrinsics have to be strong. If I want my flexor pollicis longus to work for my interphalangeal joint, I need the metacarpophalangeal joint to be stabilized by the thenar muscles. Okay. So for that, the flexor pollicis brevis or the abductor pollicis brevis or the adductor pollicis, okay, and also you have the opponent's pollicis, okay. So you have these 4 muscles for the thenar. Whereas here, hypothenar, we have a trivial muscle called as the palmaris brevis, which may be absent in 90% of individuals. And you might see that the rest of the muscles are flexor digiti minimi, abductor digiti minimi, okay, and you have the opponent's digiti minimi, because the cupping action of the palm comes, you can see thumb is going towards all the fingers, okay, that's also opposition, little finger coming towards other fingers, okay, so that's also opponent's digiti minimi, okay. And these muscles have to be trained, but remember that training the intrinsic muscles is more important. They are the stabilizers of the palm, hand, and after that you train the extrinsic muscles of extensors, digitorum next, and then fingers extension. After that you train the flexors. It's not a grip problem, you just give the smiley ball, patient keeps doing this. No, it will not. Patient will get fatigued earlier if the extension antagonistic activity is not there. Okay, if that stability is there, easily the strength will be getting better. Okay. Most of the other fine motor training also it influenced by the wrist stability and hand especially. Remember the physiology, they are the largest mapping in the brain. So any kind of a dysfunction in the hand will have a central sensitization very fast, and patients will have altered recruitments or activity in the palm because of pain plasticity or representation in the brain there. Okay. So you need to do the imagery, mental participation more, educate the patient more to understand the movement. So that's the implication for rehab. Okay. And in a post-traumatic stiffness after a Colles fracture, you are going to give the mobilization, all the kinematics, you are going to give the glides. But most important part, the vascularity is very important. If the vascularity to the palm is improper, what will happen is patient will have temperature thermal intolerance to heat or to cold, okay, leading to autonomic symptoms and signs in the palm, which is again a manifestation of shoulder hand syndromes or complex regional pain syndromes, reflex sympathetic dystrophy. Okay, so various spectrum of autonomic disorders, okay, which involves sweating abnormalities, the skin texture abnormalities, and also loss of hair. Okay, so a lot of difficulty, sleep disturbances because of the pain from the wrist. Okay. So what we see here, when you are talking about holding or weight bearing, okay, weight bearing means you can weight bear on the palm, okay, or you can weight bear on the fist, okay, and especially for the push-ups activity we do that. Okay, the push-ups could be done as an exercise, or push-ups could be done for transfers. Okay, so both the ways you are going to train the subject depending upon the grip strength. So if the strength is good, then fist and then you do that, because when you do fist and then you do the push-ups, okay, that means this wrist stability also you are training. Okay, so you are getting a co-contraction at the wrist, so it will enable more better functional training. Okay, advanced training. Unstable surfaces also patient will be able to handle. But if you are doing a wrist extension and then you are doing extensors, will be maximum passive because they are not working. The joint is locked passively. Okay, and flexors will be the one which will give the pushing force, and then the subject will be able to do. Okay, so other functional activities like writer's cramp. Okay, some things like to do with the vascularity. So remember that comes predominantly because extensors weakness, and extensors, I told you, wrist extensors synergistically involved with the pronation. So in the subjects who have more pronation and they are writing, for example, okay, excessive pronation and then writing, after extensors are fatigued, so wrist will flex. Because wrist is flexing, active insufficiency both the areas, so finger flexors will not work. So they demand more blood circulation, so they go for ischemia and then having a cramp. Okay, so the subject, it's totally difficult to continue if the student is writing an exam and gets a writer's cramp. Okay, many of us would have faced this with the change in handwriting as we write, and we tend to go like this. Okay, initially we might start like this and write, and fatigue, and then after that we go like this and then like this, and after that we will feel fully numb, and after that we'll be shaking the forearm to restore the arterial circulation, and then we feel momentarily better, and then we might initial that 3-jaw chunk. Okay, this is the hold for the writing, okay, which we usually recommend, okay, when subject is holding this. Okay, so when you are writing like this, if fatigue comes, what will happen? This grip will change to more fingers will be holding. Okay, middle finger also. Okay, up, and then more. Okay, so this is the compensation that happens. If ergonomically what we give as a assistive or a modification of the design of the pen is, you give a larger pen. Okay, that means less load on the distal joints. Okay, so we might give a bigger handle here, so that subject can hold it here in a bigger position. Okay, so that end range, inner range flexion of flexor pollicis longus or flexor digitorum profundus, okay, it's not happening. Because it will demand more energy. As long as more distally we are using, more energy demand, which will make multiple muscles to work. So energy conservation techniques also we use larger joints to be used more than the smaller joints. Okay, so we give this bigger handles and modifications. Even in the crutch modification, we have elbow crutch. After the elbow crutch, we have forearm gutter crutch. Okay, so that is we are using the elbow. Hand is used just for support. We don't grip. Okay, why? Because it's the rheumatoid hand deformity is there, so you don't want to use and overload the muscles and create an energy depletion. Okay, fatigue will come, then joint damage will be more, then joint deformities will accelerate. Okay. When you talk about the mechanics of the deformities, wrist drop, it's characteristically the muscle weakness. And whereas a flexion contracture in hemiplegia which comes is because of overactivity of the finger flexors, long finger flexors here. Okay. Thumb, which is in the rotation, okay, 90 degree it is rotated away from the other fingers. So if the thumb becomes in the same plane as other fingers, it's adducted and also externally rotated, then it becomes a ape thumb deformity. That comes because of the weakness of the thenar muscles, secondary to median nerve injuries. Okay. The next, of course, you see for the deformities in the thumb, which can be trigger thumb, the conditions, for example, flexor pollicis longus, tenosynovitis, okay, the tendon, where you get inflammation there. Also, inflammation of extensor pollicis longus and the adductor pollicis longus, both these tendons, where it will create a eccentric load. I was telling you about the outer range contraction when you finger flexion when you are doing, and then ulnar deviation. Okay, because they both assist in radial deviation. Okay, so this when you do, the elongation comes. This is the mechanics of the Finkelstein's test, the special test for diagnosing decurrence tenosynovitis. Okay. The next, of course, you see for fingers, the palmar fascia contractures, tightness. Arch is there, okay, the cupping shape of the palmar fascia is there if it is normal. If it is tight, what will happen? The fascia will become like this, okay, it will become flat. And when it becomes flat, dupuytren's contracture, okay, which will involve the third and the fourth fingers to go into a flexion because of the main line of action of the palmar fascia. Okay. The next you see for trigger finger, similar to the trigger thumb, so we will have for the again the synovial sheath friction. For example, layers of synovial sheath is present. Okay, tendon is gliding. Okay, there is superficialis tendon, there is profundus tendon, both are gliding. Individual synovial sheaths are there. Okay, so you get what is called as thickening of the synovial sheath. So it is not gliding, okay, properly. That scar gets stuck, and after that, it gets released. So this can happen when you flex, locked, okay, and then after that, tuck, okay, with the sound. So that happens in trigger finger. Usually happens in third and fourth fingers, the finger flexors. So next, of course, in you are going to see for trigger points in hypothenar, thenar, that is also common. Okay, myofascial injuries, and ulnar side triangular fibrocartilage complex. Radial snuff box I was telling. There you can palpate the scaphoid fracture. Okay, and medial side ulnar snuff box is there. Okay, flexor carpi ulnaris, extensor carpi ulnaris between that. Okay. So this, if you do ulnar deviation, you can feel that ulnar snuff box. It's not such a big snuff box. Don't try to sniff from the ulnar side. You can only sniff from the radial side. Okay. So remember here, what is important here is the fibrocartilage can go for degeneration in elderly or in athletes like cyclists. Okay, they are driving, so in extension and ulnar deviation, jerky. Okay, they go for cross country biking. Okay. So they will get that impact, so that will go for a injury. and you will find that ulnar deviation with supination pronation, the ulnar grind test. Okay, so that is the mechanics there. And coming to the finger deformities, remember, if there is avulsion of the extensor digitorum tendon, DIP, distal interphalangeal joint, will flex. Once it flex, PIP will extend. Okay, then later MCP will flex distal to proximal. This is called as the mallet finger deformity. Whereas the reverse, first starting with the metacarpophalangeal joint flexion, then extension of the PIP, and then the flexion of the distal interphalangeal joint, that is called as the swan neck deformity. That happens because of oblique retinacular ligament tightness. Okay, that happens in contractures. It comes after rheumatoid arthritis. Okay. Another deformity in the finger is the Botanaire deformity, where extension of the MCP, flexion of the PIP, and the extension of the DIP. Okay, so this is the deformity there. So remember, these two are opposite deformities, the swan neck and the Botanaire deformity. It can come just because of the connective tissue, inflammation and shortening adhesions. When you are talking about what is called as neural, okay, you have median nerve which is crossing anteriorly under the flexor retinaculum. So wrist extension will produce tensile loading on median nerve. Superficial radial nerve is loaded when you do the ulnar deviation with the thumb flexion. Okay, and the main radial nerve you can load it with the wrist flexion in the pronation. Okay, and ulnar nerve, yes, radial nerve, radial deviation. Okay, pardon me, radial deviation with wrist extension and pronation. Okay, so ulnar nerve here at the Guyon's canal. One more aspect in the ulnar nerve and the hypothenar muscles here is the carpenters or the vibration tools, drilling machines. Okay, they use repetitive ulnar deviation, so creating trigger points in the hypothenar muscles called as hypothenar hammer syndrome. Okay, hammering action and all that. Okay, so it's the entrapment of the ulnar nerve in the Guyon's canal. Carpal tunnel syndrome is the entrapment of the median nerve in the flexor retinacula. Okay, so Raynaud's disease, vascular diseases which can affect the arterial component of the hand, blood circulation. Suddenly the hand will be very cold. Even in a warm climate, your hand will be very cold. Okay, so that is Raynaud's disease. It's common in smokers. Okay, thromboangiitis obliterans, arterial. Venous, most of the time we give IV line. Okay, the intravenous line for the injections and procedures in the hospitals, for example. And if they don't replace the IV line every 48 hours, sometimes the inflammation of the vein will happen, bluish discoloration will happen, and the pain will be there. That is called as thrombophlebitis. Okay, these are all a differentiation. Okay, different parallel perspective for the wrist and hand. And try to see that some are vascular mechanics, some are neural mechanics. Okay, if you do like this, it is actually extension of the median nerve. Okay, tensile loading on the median nerve. Okay, so you can get numbness in the region of the thumb, carpal tunnel syndrome. But if the same, if you do this, compression on the median nerve also can lead to carpal tunnel syndrome. So one is vascular, this is vascular because compression, whereas this is neural elongation. Okay, tensile loading. So both can be mechanically influencing the patient's symptoms. Okay. Hand is a very wonderful region, but unfortunately very neglected in physical therapy. Occupational therapists have taken over the role of the hand, and they train fine motor activities and occupational training, handwriting training, okay, a lot of things. So it's unfortunately, but it has branched from physical therapy. So physiotherapists need to know this when they refer the patients for occupational therapy, or they treat the patients in the absence of an occupational therapist. That is also important. Plus, if you have interest that I am not a specialist in only regions, or I am not a specialist in techniques, I have to be specialized in managing another human being, okay, as a clinician. That means you have to treat the patient, okay, not treat just the region. Okay, so remember that. And now the session is open for questions, okay, if anybody is having. We have Dr. Jayanta Datta and Dr. Ritu here commenting. Okay. Give a space for questions and then see if there are no questions. We are ready to close this session. Evening, the webinars on lumbar spine and pelvis will be there, and tomorrow I am going to wind up with the hip, knee and ankle. Okay. Morning can be hip with knee, or evening can be the foot and ankle. Okay. Evening means my evening goes on till 12 midnight, so it can be after 10 p.m. Okay. Although I know that at the same time all around the world it will be morning actually. Okay. So there's nothing wrong with taking 11 p.m. Okay. So for those who have a habit of sleeping at 9, okay, 9 p.m. remember that it is 9 a.m. okay in Los Angeles. Okay. So you're sleeping in the day. Okay. So that's why here you see okay, Dr. Abdul Kalam's words. Okay. He mentions the value of sleep, that people who love the dreams will like to sleep because they get dreams. But to people who live the dreams, okay, they'll not sleep. Okay. So good luck to you all. See you. Bye bye. Enjoy your day and stay connected, stay updated. Be with the AOMPT. Join the celebrations. Join the CSMT. Join the COMPT. Also the CNMT, the upcoming courses of the AOMPT. Okay. All people who are participating either through the Facebook or they are participating here directly in the center at Bangalore will receive the certificate, e-certificate that they participated in the inauguration and the launch of the CSMT program. Even though you are not a registrant of CSMT, okay, so you will get the certificate for the inauguration ceremony. Okay, so most people, I want all of you to see the center virtually at least. Okay, so God bless you all.